Good morning, everybody, and welcome to this year's Sachs Summer Scholar Innovation Showcase. I'd like to extend a warm welcome to everybody who came in person today, and as well to our friends online. Today's event is one of the highlights of PCCI's year. We have 7 outstanding presentations from 7 outstanding scholars this morning, covering all sorts of topics from preterm birth, suicide risk modeling, large language models, digital engagement, all and many more. So to begin with, I'd like to invite Steve, Capriya, Aida to come and speak a little bit about the program.
Well, welcome again. Just as Aaron mentioned, this is the highlight for us for the year because we have so much fun every year, just not only welcoming the students, but getting to know them, getting to see the amazing work and progress that they make. And they literally bring so much joy and energy and creativity to everything that we do. So this is sort of a culmination of the 10 weeks that they've been working on alongside our team to advance projects that are already having an impact across the community. What I think is so special about this is that this is not just helping them learn and advance, but they're working on real projects. They're working alongside our team. And they're bringing so many new perspectives that it helps us see things from a different angle, helps us think differently, and they literally elevate everything that we do. And this year in particular, this is a special group. I always say this sort of every year, but the mantra that we use at PCCI is around raising the bar every time we do something. And I can honestly say that you all have raised the bar once again. And that was evident from absolutely day one. Like, I don't know how it happened, but I walked in literally hours after you guys met each other, and you felt like you've been friends for years. And you were just comfortable with yourself, you're comfortable with each other, you're comfortable with our team. And that from get-go set a stage that just carried throughout your whole internship. So a huge thank you for everything that you've done, and so excited to see what you're going to share today. I also want to just thank the mentors that have spent time the whole summer working with you. We don't ask people to do this. People volunteer. Actually, we have to sort of limit because we don't want to make sure that you have that one-on-one interaction. So this is something that people want to do, that they're excited to do. I want to just also thank the leadership team. You hear Capriya and Aida in a second, and Albert and others that spend months before you even get here to prepare everything. And finally, I would like to thank our partners because without their support and access to their programs, their data, to their team that are carrying these on the front line, this is not possible. So a huge thank you to all of you for enabling us, not only at PCCI, but doing the summer with the intern to take on this work and help to advance it. So there's one other person that I'm going to thank in a second, who is being the co-founder of this. But before I do that, let me turn it over to Aida and Capriya for a few words from their end, because they've been the champions for this for years, and I know they're particularly excited to participate and to help to lead this. So Aida and Capriya, I'll let you guys take it.
Thank you, Steve. Well, it's a real pleasure and honor to be here, and especially very honored for all of the work and that you have spent this summer with us working on real life problems. We talked about leadership doesn't start with the title. It starts with really curiosity and really purpose to solve meaningful problems. And I feel like each one of you in your own way have demonstrated that. You've been curious, you've collaborated with mentors, others, and I think it really shows in your work. And I'm really excited for you to really celebrate everything you've done and where this could go next. I think the generation and the new changes in your hands, and look forward to seeing what you guys will be able to do in the future. So thank you so much, and keep leading with purpose and with heart, and we'll do great. Thank you.
To that note, here are a few words of encouragement for women in data science and technology. Good morning, everyone.
Good morning.
Today, I want to remind you that you belong in every room where insight is needed, where solutions are created, and where impact is made. Your presence is not by accident, it's by purpose. You are walking proof that excellence, curiosity, and leadership know no gender. For too long, women were told that STEM wasn't our place. But here you are, coding, calculating, creating models that shape industries and move futures forward. Never underestimate the power of your voice, your vision, or your values. Whether you're designing an algorithm or asking the hard questions that no one else dares to ask. Why? Because you are not just working with data, you are speaking truth through numbers, revealing patterns that change lives. So if the role feels lonely or the seat at the table feels uncomfortable, remember this, you are not alone. Look around. This is your tribe. This is your circle of builders, believers, and barrier breakers. Let's continue to lift as we climb. Let's challenge systems, mentor the next generation, and lead with both intellect and integrity. And most of all, don't shrink. You don't have to fit the mold. You are made to stand out. Keep rising, keep coding, keep leading. The world needs your mind. The world needs your voice. And at this moment, it's just the beginning. So walk boldly, ladies. You are created for it.
Yeah, Naida, that was fantastic words, so inspirational. Before we jump into the presentation, which is I cannot wait to do, and I'm sure all of you did the same. I want to just bring you back to 7 years ago when we actually started this program. And we started it in honor of Michael Sachs. Michael was a mentor of mine for my whole career, but more importantly, somebody who really focused on advancing women in healthcare analytics and technology throughout all his companies. Michael was a PCCI board member and unfortunately passed away at a way too early age. So 7 years ago when we started this program, got together with Michael's son David, and together we thought, what an amazing way to continue Michael's legacy, raise the PCCI in addition to all the other places that he's impacted, and create something that really resembles what he wanted to do and has done for his whole career. So that's how the Sachs Summer Scholars started 7 years ago. And David has been a partner and a supporter of this since the very first days. Has been very actively engaged. So a huge thank you to David and Diana and the foundation that they've been sponsoring this. And I would love for as we've done every year, for David to offer a few words himself. So David's online, and I know that we have to switch some microphones here. So.
All right. Well, thanks, Steve. I appreciate it. The Sachs family, Colorado, is very excited to continue to support the Sachs family or the Sachs Summer Scholars. My father, Michael Sachs, was very focused on finding different viewpoints on healthcare and the trends. And back 10, 20, 30 years ago, there was women were not as engaged with analytics and digging deep into the healthcare, and that was a great opportunity for the companies that he led to get different viewpoints, to delve into the data and understand different trends that can really change the outcomes in healthcare specifically. And one thing I'll leave you with is the past does not predict the future, and so always look into different trends. And we're excited to be marching into the future together with everyone here. And one last thing, don't forget to leave your numbers on your slides, because Michael would always put the slides on the table when he was meeting with healthcare executives and flip from page to page and never in order, because life's never necessarily in order. So be ready. And we're excited for the presentations today and the great future that you're gonna bring for everyone. So thanks again, and looking forward to today. Thanks.
David, thank you so much. This is the first year that I did not remind our team about page numbers. Done it every year since, so let's see if, how well we've done. And also, Michael, when he walked into a room, he immediately started to rearrange it because it was always sort of needed to have the right flow. Dean rearranged the room. I think was set up beautifully. So with that, Aaron, to you to actually start the presentations.
So today, here's a little overview of what I'm going to discuss. I'll start off by telling you a little bit about myself, and then I'm going to dive into my project. I'll introduce my methods, results, and then the lessons I've learned along the way. So a little bit about me. I'm currently a statistical science PhD student at Southern Methodist University here in Dallas, but I am originally from Western New York, which is the snowy picture that you'll see on the bottom left of the screen. And a fun fact about me is that I'm a former ballet dancer, and I currently do ballroom dancing. So now for my project. My stakeholder was the Parkland Community Health Plan, or PCHP. It's the Medicaid organization in North Texas, and it services 7 counties, including Dallas County. And my goal this summer was to develop 2 predictive models, one for prenatal visit adherence and one for postpartum visit adherence. And to do this, I had to create 2 cohorts, a prenatal cohort and a postpartum cohort. So I used data from 4 different sources. I used PCHP claims data over a 2-year period from January of 2023 to December of 2024. I also used member demographics data, member enrollment data, and CVC data. And for those of you less familiar with CVC, it stands for Community Vulnerability Compass. And it's basically a tool that PCCI developed to determine non-medical drivers of health. So to create my cohorts, I started with the PCHP claims data. And I used a mixture of pregnancy and visit type diagnosis codes for the prenatal cohort. And then I used delivery diagnosis codes for the postpartum cohort. From there, I added on member demographics data, filtering it for females between the ages of 11 and 55 years who lived in the 7 PCHP counties. And then after that, for the purposes of my models, I was following HEDI standards, so the healthcare effectiveness data and information set parameters, which means I was only looking at prenatal visits that occurred within the first 42 days of eligibility, which I use member enrollment data to define. And then for the postpartum cohort, I was only looking at visits that fell within the 7 to 84 days after delivery. And again, of course, I used delivery dates to define that. And finally, I added on CVC data, and I did that at the zip code, block group, and census tract level. Why is this important? Why does this matter? Well, prenatal and postpartum care are integral to the health of mother and child during and after pregnancy. So being able to have models that actually predict whether or not a patient is likely to attend a prenatal or postpartum visit is crucial in better serving the patient population. And it ensures that patients receive the care that they need. So here we have an overview of my 2 cohorts, and you can see that about 55% of the prenatal cohort did not have a single prenatal visit within those 42 days of eligibility. The number is even worse for the postpartum cohort. 58% didn't have a single postpartum visit within those 7 to 84 days after delivery. So my goal this summer is, of course, let's see if we can make those numbers better. I also wanted to examine the overlap between cohorts. There were quite a number of patients, over 22,000 in fact, that did overlap. So that was good to know. But you can see that only 16% of these, or a little bit over 3,500, actually had both a prenatal and a postpartum visit within the specified time periods. So I began my analysis with a little bit of exploratory data analysis. Here you have the age for each cohort, and they're following roughly the same breakdown. You can see most patients are falling between 20 to 29 years of age, and we've got the average age of patients for both cohorts about 28 years. I also examined ethnicity. So you can see Hispanics and Blacks for the top 2 ethnicities represented. Then finally, I wanted to get a sense of, okay, where are these patients coming from? You can see about 78, 79% are coming from Dallas County, and then less than 1% are coming from Navarro County. And then the breakdown kind of between the 2 cohorts is pretty similar, a couple minor differences. I then turned my attention to the CVC data. What I did is I looked at the top 5 zip codes within each county, and from there, I extracted themes that were occurring most frequently. From that, I grouped it into 3 different vulnerability categories, low, medium, and high. And this was kind of a helpful breakdown because it informed what variables I might want to consider including in my models. You can see that households without vehicles, neighborhood safety, clean air, and literacy were all among the lower vulnerability, whereas asthma, disease burden, walkability, and obesity were showing up as higher vulnerability. I also performed a little bit of bivariate analysis. So here you have the visit attendance by ethnicity. So you can see the number of patients within each ethnicity group that actually had a prenatal visit. And if you recall from one of my earlier slides, Hispanics and Blacks were the 2 most frequently represented ethnicity groups. However, here, both of those groups have less than a 50% prenatal attendance. I did the same thing for the postpartum cohort. And again, the Hispanics had less than 40% postpartum attendance. Interestingly, Blacks actually had a better postpartum than they did prenatal visit attendance. So they were at least at 50% here. This graph is interesting. So if you look at the 2 maps, you can see that it's actually kind of flipped. So for Dallas, that had the best prenatal visit attendance and worst postpartum visit attendance, whereas Hunt County had the worst prenatal visit attendance and the best postpartum visit attendance. So just kind of interesting again to understand kind of where our patients are coming from and then trying to help inform the models. I considered many different model types. These were the top 4 that seemed to perform the best. You can read the brief overview on the slide behind me. Basically, in a nutshell, logistic regression is just a linear model predicting a simple yes or no outcome. So in our case, whether or not a patient's going to attend a visit. Penalized logistic regression kind of builds on this. It adds some penalty terms, tries to prevent against overfitting, and basically improve feature selection. And then principal component logistic regression says, okay, you've given me these input features. I'm now going to shuffle them into my own set of principal components and apply logistic regression to them. And then finally, XGBoost is a machine learning model. So here are all the features that I considered, color-coded by category. You can see demographics data, CDC data, we've got different health claims, diagnosis data. And for these are all previous conditions that patients might have had that I use the claims data to define. And then at the bottom, there's some variables specific just for this. And I want to draw your attention to the CDC variables. These I color-coded, or I binarily coded based on whether it was a low vulnerability or high vulnerability. So for example, for asthma, I was looking at, okay, is this area high vulnerability for asthma or not? And I did this at the zip code level, the census tract level, and the block group level. So after fitting the models and performing model diagnostics, these were the top 3 prenatal models. And you can see that principal component logistic performed the best with about an 85% accuracy. And then logistic regression and penalized logistic regression were pretty close behind. So that's actually pretty good. And if you're wondering what the no information rate is on the bottom of the screen, that's basically the rate of random chance. So as long as your model is performing better than that, it means it's providing some meaningful information. The way the principal component logistic regression model works by shuffling all of the original features makes it kind of hard to understand what the coefficients actually mean about the model. So what I did is I mapped every single coefficient back to the original principal component feature. And then I extracted the top 5 positive and top 5 negative contributing features and found the odds ratios for each. So that's basically what this graph shows. So any bars that are green are showing that that variable has a positive association with prenatal visit attendance. And any bars that are gray are showing a negative association. So for example, if we look at ED visit, the very top, if a patient previously had an ED visit, they are 0.62 times as likely to have a prenatal visit, holding all else equal. In other words, they're about 38% less. I did the same thing for the postpartum model, and here were the top 3 postpartum models. You can see logistic regression performed the best with about a 64% accuracy. Not as good as prenatal, unfortunately, but it is still better than the no information rate. So that means that this model actually does provide some meaningful information. This graph is very similar to the one that I showed you for the prenatal model, but this is showing all of the significant postpartum features. Again, the green bars are showing positive associations and the gray bars are showing negative associations. So for example, if a baby is born in December, they are 0.45 times less likely to attend a postpartum visit, or about 55% less likely, holding all of the variables. I have learned so much throughout this internship. And I think one of the major takeaways for me was just how tricky it can be to work with real world data. In an academic setting, you have data sets, and yes, they're large, but they're not as massive as 5.5 million rows of claims data. And I think trying to learn how to merge these real world data sets, and it was complex, it was computationally expensive. I had to learn how to work with my computing resources in the most efficient manner possible. And while it was a learning curve, it was a really beneficial. And secondly, and most importantly, there's always something more. There's always a new way to refine your methods, or your data, or your modeling. And I think the second half of the internship really taught me just how crucial that refinement process is. So although today marks the end of the internship, it's not the end for this project. There are always new avenues that could be considered, such as adding new features or trying a different model. And I am just so excited to see what direction this research might go. Lastly, I wanted to share a couple of pictures from our internship experience. I've had such a wonderful summer here at PCCI, and I'm so grateful for all of the opportunities, lessons, and friendships that I've made. And finally, very special thank you to my mentor, Sandra, for always answering all my questions, Dr. Yolanda for all her clinical expertise, to PCHP, and to everyone at PCCI for providing such a supportive and welcoming environment. Thank you.
Very nice work, showing some interesting mathematical models that can be used to improve adherence down the line. And in that light, from having done it for a long time, the key to me that we need to ask ourselves, and I challenge all of you, is how do we make it easier for people to do the right thing to themselves?
That's a great point. Thanks.
Excellent presentation.
Thank you.
The Spanish angle was very interesting. We have a lot of data that shows language discordant care leads to worse outcomes, and yet you showed that Spanish speaking actually has better outcomes for postpartum follow-up. Do you have any hypotheses as to why that is?
If we look at that slide, I will go back to it. You can also, what was interesting to me is that the different ethnicity groups and then language groups, their importance in the model and whether they were significantly contributing like positively or negatively actually changed based on the model. So it's also possible that while the Hispanic or like the Spanish language might have added to like an increase of the visit adherence, it might have been decreased somewhere else in terms of whether it's the Hispanic ethnicity or another ethnicity. So yes, it is important, and yes, it does impact for this specific model, but it's also possible that if you consider it in relation to some of the other features, that would lead to a slightly different outcome in terms of the coefficients.
Wonderful presentation, and thank you.
Thank you.
And you may not know the answer, but I know we have some PCHP folks in the room, but what are they going to do with this information now that you can understand adherence before the baby's born and after? So what is it that they're going to do with that?
That is a great question. I think looking at the different features that were significant for the two different models is a great starting point, because you can try to see if there are ways, like if you know, for instance, that a baby that's born in December, November is maybe less likely to have a postpartum attendant visit. Those are, that's the holiday season. People are busy. It might just be that there's ways to kind of remind patients more frequently of a visit if maybe they're just forgetting about it, or find ways to kind of work with them with their schedule to maybe provide more appointment times and things like that. So I think these, the coefficients and the variables that showed as being important are great places to start. And then after that, you can see, okay, is this having a positive impact in the way that we think it might based on the models? And then kind of going from there and continuing. So just refining your models of process, I think refining your method is also a process.
Good morning. Excellent job. This is really fascinating to be able to see that. A couple of points and then just your insights on this too. So I really appreciate the fact that how you correlated it with the CVC and looking at that as we look at zip codes and we look at the vulnerabilities in these different areas and the non-medical drivers of health. In terms of your period of time, which was actually insightful that you had that calendar year 23, January to 2024 claims-based data, which is great, by the way, so you can capture them anywhere. I would say one of the things you may want to look at too is that during that time, we were also, many of us implemented processes to be able to screen patients for the health-related social needs as a requirement around CMMS and Medicare and the Joint Commission and things like that. So it would be very interesting to actually correlate that data to what you actually see in terms of chart-based data and seeing where you are and how that correlates to the CBC. The 5 screenings were in terms of food insecurity, housing instability, transportation difficulty, intimate partner violence, and also utility difficulties. Right? And so if you're able to look at that and then you correlate it with that, you may actually even see where your low vulnerability may be even higher. Because one of the things we're actually seeing in our area on Tarrant County side is that we're having, last year, during that period of time, the highest vulnerabilities were around food insecurity with health-related social needs. This year, interestingly enough, it's housing that's leading the way. So you may want to think about that way as you're looking at that and correlating that, you'll be able to target your actual zip codes too with that data and be able to see what kind of community partnerships and interventions you may be able to do.
That's a great idea and definitely a future avenue for this research, especially in terms of adding new features and looking at that. That's a wonderful point. Thank you.
Hi, I'm Paula Turkey from PCHP. So I really appreciate the work that you did over the summer and answering all of my questions while you were working on your project. I was very interested in the difference between Dallas County and Hunt County.
Yes.
And I'm looking forward to Albert's question, what are we going to do with this? One of the things that I'm looking forward to is sharing that with the Parkland team, because there is now a mobile unit that is dedicated to Hunt County. So I think that that will be very helpful in identifying how we can use that unit to bring up the utilization and the attendance to prenatal there.
Yes,
that
that's
location.
wonderful. And then it would be interesting too to track over time and see kind of how that unit helps to increase or impact these percentages. Thank you.
Thanks again.
A little bit about me. So I'm a master student from University of Southern California, and my major is applied data science. I really love painting. So those are the paintwork from last year. I also have a lovely cat, and I brought her to many different countries. And sooner we're gonna start our road trip together. Okay, so let's first talk about the project. So suicide has been one of the leading causes of death in the United States, and many research shows that the suicide rate has increased by about 30% from 2000 to 2018. And clinicians have been trying hard to reduce the suicide risk and saving more people's life. They will also be trying to detect the early sign of suicide so they can intervene in time. One thing that researchers found is that about 77% of people who die by suicide, they visit to see their doctors within a year before their actual death. So that's what got Parkland's attention. So in 2015, Parkland implemented a universal suicide screening program. That is, for every patient that came to the hospital, they will get screened for their suicide result. And the doctor will review the result and make some early prevention based on their risk level. But that raises a critical question. So is the screening result really helpful in detecting the patient at risk? So does the universal suicide screening provide clinically useful signal on predicting the suicide event? So here's what my project is here to answer this. So I will use a predictive modeling approach to evaluate how effective the suicide screening really are, and whether it actually helping people detecting the suicide risk. Thanks to all my stakeholders and UT Southwestern and Parkland for incorporating to make this project. So what is suicide screening? On the left, you can see a question here that contains of 6 different questions. Each question asks a patient whether they have any suicide idea, suicide thought, suicide intent, or even suicide attempt. And based on their answers, they will be classified as either no risk at all, moderate risk, high risk, or historically high risk. And in our data, we see that 96% of patients fall into the no risk group. And the other three categories accounts for 1% each. Let's first take a look at the data that I used. So the data is from Parkland Health and also the state mortality data. There are 3 million rows and 500,000 total number of patients. So each row represents one encounter, and the patient may have exactly one encounter or multiple encounters. We also have 132 columns. Those are spanning across 5 different categories. Demographic characteristics within an encounter information, the behavioral health indicators, suicide screening results, and finally, the mortality features. Let's see the pattern of the for suicide-related behavior. These are very important in my analysis because the model is built based on identifying these suicide rates. So you see the distribution is in a funnel shape. That is because there are fewer and fewer cases when the when we move up the severity scale from the suicide ideation to the self-harm to suicide attempt and eventually to the death. So what is surprising here is that from the table we see that the proportion of female is larger than the proportion of male in the data. However, male tend to have more cases than female in terms of these 4 different suicide events. Now let's move on to see some behavioral risk indicators. So here I build a correlation network to see how different risk factors correlate to each other. In the left circle, you can see there are 5 nodes: PTSD, bipolar disorder, schizophrenia, suicide ideation, and BPD. These 5 indicators form a tightly clustered group, and because they are close to each other and connected by a line, so that means that these indicators may frequently appear together in the same patient, and they also may influence each other. Similarly, in the red circle, you see that intentional self-harm is connected with multiple injury methods, and there is a very big line between the self-harm and sharp object, which indicate that these 2 factors have positive correlation with each other. So in other words, when we see a patient that has an intentional self-harm record, it is also very likely that this patient may use the sharp object as a method. So coming back to our original question, is the universal suicide screening really helpful for predicting the future suicide risk? So here I will use 3 different machine learning algorithms: random forest, X-ray boost, and logistic regression with 1-year prediction. Let's first take a look at the cohort design. So assume that this patient came to the hospital 5 times from 2016 to 2020. So we pick the most recent clinical encounter before the first suicide event as the anchor encounter. And then we want to predict whether this patient has any suicide event within a year of the anchor encounter. So if you do find any events, then this patient will be flagged as a positive case. So all the other information before the anchor data will be summarized. So the model will learn from the past record to predict whether this patient will have any suicide within a year. Okay, here's my experiment design. So I first extract features from data, and then I build 2 types of model. One without the suicide screening variable, and one with all the suicide screening variable included. And these 2 types of model will go through the model training and optimization process. And after each iteration, it will give us the model with the best performance. And finally, I will compare the model without the screening feature and the model with the screening feature to decide which one is better. Okay, so here comes to the results. So after trying different optimization strategies, I got the highest performance model for each algorithm type. So overall, you can see that model with screening had a higher AURC and balance accuracy score than the model without the screening. And specifically, we see that actually Booth is the best model among the 3 different algorithms. And similarly, logistic regression stands out that has the highest AURC score. So now I will make a table comparison between the for the 2 best models. So in reality, when we decide whether the patient has any suicide risk, we really don't want to miss any of the positive cases. So it's dangerous that if we misclassify a patient that's truly at risk. So one possible solution is that we can intentionally include all the possible positive cases. But they may also end up like identifying more patients that are not at risk. So here I ran the experiment. So I that the 2 model has the same false negative, has exactly the same number of false negative, and then we can see how they differ in the false positive. We see that the model with the suicide, so false positive is that we predict that this patient will have a positive. This patient is at suicide risk, but actually by instead is not. So the model incorrectly classified a no-risk patient as high risk. So we see that for the model with the suicide screening, there are 10% fewer of false positive than the model without the suicide screening. Now let's see the top 15 most predictive features from the best 2 models. On the left, you see that heavy smoking status is the most important feature to the model's predictive power. However, when we add more screening results into the model, it goes down, and now the positive screening result come to the top and become the most important feature. Also, so when we have limited resources, we only want to consider the most at-risk patient. So here I also tested model performance when we focus on different top percentage of patients that predicted to be at risk. So we see that when 10% of patients are identified as at risk, model without screening does a better job. But as we increase the percentage, the model with screening wins. So this shows that screening becomes more useful when we are trying to find more than just very highest risk. Okay, finally, come to the summary and limitation. So far, I've tried different models with 3 algorithms, and they all prove that the suicide screening gave us a moderate predictive improvement to the model. And also, those screening features are ranked as highly predictive to the model. But there are also some limitations. So because we have a very limited suicide events in the data, that may introduce some bias to the model. So in the future, we have to try different model optimization strategy and also different model types to see how the results gonna change. In addition, we can change the patient-based model into the encounter-based model for improving the utility. And lastly, we can also add additional features such as medication into current model to see if the result will improve. So lastly, I want to say a huge thank you to my mentor, Alex, and Dr. Jackie for helping me along the way. And also thank you so much for all the PCCI team for giving me this opportunity.
I just have a comment. Thank you very much. I certainly enjoyed this work. First of all, what led you to this particular project? And second of all, this would be very interesting to the Jordan Elizabeth Harris Foundation in Fort Worth, because they focus on these issues as well.
Yeah, so suicide is like the common thing that most people are curious about. So if we can find a way to reduce suicide rate, that would be very helpful for and follow work. So that's why I chose this topic before I came to this internship.
Hey, Rachel. I'm Ashley from PCCI. Is there anything that you found while working on this project that was interesting or was outside what you expected to find, or even just have changed your view on this?
Yeah, so one thing that's really make me surprised is that, so I was thinking like the male have higher risk than female, and that's also shown from many, no, like the female will have a higher risk than male, and that's also shown in many research paper. But in fact, in our data, we have more male cases that are ranked as high risk. That's something I found is.
Hello, my name is Mohammed. I'm PCCI. So my question is, so when it comes to suicide prevention, I mean, what else, like what other, because outside of just screening, what other preventions do you see, you know, in the future?
You mean like the prevention for the suicide or both?
It's like from your research, I mean, that you gather, I mean, what do you think could be more to like help these people, you know, prevent obviously suicide, just outside of screening?
Part of the internship.
Exactly.
So I think the first important thing is identifying people at risk, which is what we're doing here. I think the next thing, there's good research in terms of things like early intervention, so connecting people with care earlier. Things additionally like caring contact, so looking after people and doing outreach beyond the thing. And I think those are really the key three things that really this. Oh, sorry, and I'm Jackie Nayin from PCCI.
Morning, I'm Teresa Daniel, Dallas County Commissioner, and am always interested in public health, public safety issues that are going on in Dallas County. All of the members of these studies, though, were part of the system already, weren't they? They were already patients. Is that true?
Yes.
Yes.
So this is from the Parkland Hospital. That is from 2015 to 2020.
Okay, thank you.
This is AJ from Parkland PDS Group. Just have a quick question about, I think one of the ways that we can prevent is just medication adherence. And people who are, you know, taking their medication on time and everything, I think they will have a better understanding, you know, what they're going through and everything. So I think that's one of the key factors. Maybe there's another part 2 or version 2 of this particular one will take that, you know, heavily and to figure out that what are the actual reasons. So that's a thought.
Thank you so much for your presentation.
Before we get started with the project, I'd like to talk a little bit about myself. I did graduate high school last year with my associate's degree, making me the first in my family to graduate with a college degree. So I am majoring in information systems at UTA right now, hopefully getting into cybersecurity in the future for a career. I really enjoy going to concerts. I think I've been to about 5 concerts in the past year. A little expensive, but it was worth it. I have about 15 stuffed animals, and over half of them being from when I was a baby. And I am a huge, huge foodie. My favorite food as of right now is pho. Alrighty, so let's get back to this project now. During the presentation, I will introduce the problem, like what initiated the project, why we even started to begin it. I will then go over the steps that were necessary to take in order to find the results. And then I will talk about some patient demographics, some background information, and finally, next steps. Where is this project going in the future? Alrighty. A challenge in healthcare today is the abundant amount of non-medical drivers of health, or NMDOH, information that is constructed under a lot of unstructured medical note data written by clinicians. So non-medical drivers of health information such as insecurity or housing, something that will affect a patient's health without a medical need, basically. These notes are free text written by clinicians and are difficult to systematically analyze, making it hard to use data for population health strategies. To address this issue, large language models are used to structure the text, structure the data, make it more salvageable for us to use. My part of the project is to take the structured data and validate that with the CBC using maps. As previously mentioned, my scope of the project was to validate NMDOH information extracted from the medical notes to the community vulnerability compass. For the past 3 weeks, I needed to do some literature review. I needed to understand the project and its importance. I then had to understand a bit about Databricks. How am I going to use this in my project? What do I need to know? How am I going to tweak around the data? I had to then begin my data pre-processing. I obtained the data. I understood the data. I was able to aggregate the data to fit the scope of my project specifically. And then after the midsummer presentation, we made the transition from analyzing the data to making the data more visual using maps to be comparable with CDC. All right, let's take a deep dive into what non-medical drivers of health information actually are. NMDOH, previously known as SDOH, or social determinants of health, are health factors that impact the determinants of health. Are the health factors that determine and impact the health disparities. For example, utilities, food, housing, etc. Clinical notes documented by physicians contains rich information about NMDOH. The LLM helps structure free text narratives to see if patients have reported a need for a specific NMDOH domain. The Community Vulnerability Compass is PCCI's tool used to detect vulnerability at a geographical level. It has 5 different domains with 26 indexes, and the geographical levels that the CBC measures are the census tract, block group, and zip code. And my project is focusing on the zip code level. Here are the 7 domains that we'll be using for my cohorts analysis. I have financial strain, food insecurity, medical transportation, non-medical transportation, housing instability, homelessness, and mobility issues. In terms of data, I received 32,863 patient notes, which was then aggregated into 3,795 unique patients. After analysis, I found a total of 1,732 patients that responded to at least one NMDOH domain, which is what developed my cohort. All right, behind me, you see the different demographics of my cohort. You're seeing that we have more females than males that responded, which pretty much aligns with Parkland's population. Individuals ages 36 to 60 were more likely to show an NMDOH vulnerability or to report it. The majority of individuals in my cohort are white, and we are seeing more Hispanic patients than non-Hispanic. Alrighty, now when it comes to data pre-processing, we have to remember we are doing our comparison at the zip code level, but the data that I received was given to me at the note level, meaning that I had a few steps that I needed to take in order to create these maps. One of the necessary steps was aggregating the data at the patient level. If the patient expressed a vulnerability for a specific NMDOH domain, they were reported for having an affirmative. They were basically reported affirmative for that domain, regardless of other answers that they may have stated. After the patient level aggregation was a zip code level aggregation. I had to find the zip codes in which these patients were located and calculate the percentage of affirmative answers for each zip code. After this process was complete, I was able to create maps based on NMDOH information to be compared to CBC maps. Alrighty now, For our first map, we have our financial strain map for medical notes, and we have paycheck predictability for the CDC map. Financial strain is defined as the ability for one to pay for financial needs, while paycheck predictability measures the proportion of households working full-time year-round. In our financial strain map, we can see that zip code 75244, 75205, and 75208 are highly vulnerable, meaning they are not meeting financial needs. While paycheck predictability shows South Dallas zip codes have a higher vulnerability of patients not having full-time jobs. When looking at these maps, it's important to note that medical notes population isn't evenly distributed as opposed to CDC maps. Okay, the definition for food security in medical notes is the limited or uncertainty of access to adequate food. The CDC's definition is the percentage of patients who are reported on SNAP or who are on food stamps. Looking at the medical notes map, we see that zip code 75224, 75238, and 75204 have a higher vulnerability when it comes to having consistent food. Now the CDC side shows South Dallas and Northeast Dallas have a moderate to very high level of being reported on SNAP. The definitions are not exact, so we do have to pull the most comparable definition from CDC to medical notes. Medical transportation is the lack of reliable transportation to medical appointments. This is being compared with CDC's households without vehicles. Similar to the non-medical transportation map, when looking at the CDC's map, there is not a specific concentrated area that shows high vulnerability. Instead, Dallas County as a whole is showing that they are highly susceptible to not owning a house or not owning a car within their household. Versus medical notes map, which shows a low number of patients being reported for having transportation issues. This does require further analysis based on insurance status. For example, if a patient is reported for having Medicaid or Medicare transportation benefit. And then this is the non-medical transportation map, similar to the medical transportation map. Now, housing instability is the lack of individuals having the ability to maintain consistent housing for a variety of reasons. Household structure is the percentage of single parents within a household. Most of Southwest, Northwest, and Northeast Dallas have a high vulnerability to single parent households. While housing stability shows a low to very low vulnerability. It should be noted that there is a difference in granularity, which is a limitation to our analysis. Now, it is said that it is quite difficult to compare homelessness to any of the CDC indexes because homelessness doesn't really fit into any of the definitions in CDC. Therefore, we decided to compare homelessness to neighborhood stability, which shows the number of vacant housing in an area. On the medical note side, most of the map is showing a low to very low vulnerability, while on the CDC side, you're seeing that the more central and northern part of Dallas is showing high vulnerability. We are relying on what patients have said or reported, while CDC doesn't have an appropriate comparable indicator for homelessness. However, this can also be a result of cohort size, which will be expanded in the next steps. All right, there are certain limitations to availability in medical notes. So let's try to put ourselves in patients' shoes. Imagine a patient in a clinical setting quietly weighing how much they feel comfortable sharing. This time is short, their privacy feels fragile, and pressure of family members makes vulnerability even greater. For some, language and cultural norms add another layer of hesitation. Instead of expressing their concerns, patients may hold back out of lack of being judged, being misunderstood, or facing negative consequences. These factors often shape the data that is collected, limiting the full picture of a patient's experience. Now, my work here is done, but the project still continues after today. Z codes in ICD are a set of codes that describe factors influencing a patient's health, but are not related to specific diseases or injuries. Codes ranging from Z0 to Z99 are indicators of reasons for patient encounters with healthcare physicians. Z codes can be used to document NMDOH information, leading to why it's important for the team to make the Z code analysis after expanding the cohort size. They will then make a Z code comparison on the findings. They will then look at a specific population by clinic sites and or diagnosis. The presentation was just to show you a trailer to a highly cinematic movie. Alrighty, I'd like to thank our stakeholder, Dr. Brett Moran, and the entirety of PCCI's team. Thank you so much for all of your support.
Good morning.
Good morning.
I'm Dr. Tricia Elliott. I'm over at JPS Health Network as the Chief Academic Officer and Senior VP of Academic Research, also overseeing our health equity team there. And it's excellent to be able to see this in correlation also with your prior colleagues' presentation and seeing that focus. I love that you ended with the Z code piece because that's definitely where we're thinking kind of going next to, and we've done some significant work on that in Z code capture rates. It's definitely a thing you have to work with your teams to be able to do that. We've increased our capture rate significantly up to over 90% now, coming from 3%, but it took a year of work to do that. One of the things I just want to kind of say, I think that in thinking of next steps and where you are, the medical note piece you had in 2023, and as I mentioned earlier, there's been a shift in terms of documentation and capture rates, in terms of documentation in the medical note and screening rates. So I'd be curious to see from January 2024 to year to date, to see how that actually correlates now with your CBC, and if that map looks that comparison map will look very different. It would be very telling to see that. And I think the other thing that I would also say, knowledge is power. And I think it's great to be able to see that CBC, because I will say as a physician myself, to see that, if I was able to see that, wow, this is where I know you live, this is where we work, and this is where you play, this is where I understand. It's helping me to also have a conversation to create better psychological safety and coach that for my patients to say, I'm here to partner with you to live your best life. And you know where you live, work, and play impacts that. I understand from some of our data that in the area this may be a vulnerability. Help me to understand a little bit of how you're working and how you're living, working, and playing in this space, and how we can help you with that and what resources you need. Of course, I'm an educator, so that's how I'd like to do that. But I think if you could see that together and then understand that even more so, it may be something that could be important. The flip side too, with your Z code piece, I think, is to think about how you could actually help a system capture Z codes even better from this, right? And so there's that two-way street, not just to say, hey, let's get the Z codes and feed it into the data. How can you use this data to help the system capture Z codes to basically look at future revenue opportunities? So just all that.
Thank you so much for your feedback.
Hi, I'm Dr. Barry Lackman. I'm the former medical director for Parkland Community Health Plan, and my last 5 years have been spent in pseudo-retirement. And a lot of my pseudo-retirement work is around the non-medical drivers of health, particularly in South Dallas, and validating some of the observations that you have made about the prevalence of food insecurity, transportation issues, and affordable and safe housing, even the housing that we have in South Dallas. But one of the things to me that stand out in the data, and I think you highlighted it, is the discrepancy that exists, which I would think largely relates around trust. So the question becomes, how do we develop systems, and how do we develop providers, people connected to the vulnerable people we're choosing to serve, to generate the kind of trust that that we can use to help people achieve their best selves and their best life.
honestly, to your point, I would say the best thing to do or the first step to take would be to inform these individuals. They don't know that they're able to trust people just based off of experiences that they may have had or experiences that they may have heard others have had. So if we're able to inform them and they're able to go through that themselves, then I think the trust will definitely be built on.
In some of the programs that I've been involved in developing, one of the things we realized about non-medical drivers, and it's appropriate also to the delivery of healthcare, has been that the person who presents with a food problem also is likely to have a housing problem, transportation problem. And so there are too many, to my mind, too many one-trick ponies out. In one of the projects that I developed a framework called the 6 Pillars approach. And as an example, when we're developing community gardens as an answer to making food available, we're looking to train people as master gardeners in order to do workforce development at the same time. But in order to do that, you have to recognize the 6 pillars and in the design of your programs, look for how we do that. To me, one of the challenges as a former healthcare provider is how do we co-locate services so they're most easiest for people to use without attaching stigma to them.
Thank you very much for that observation. Lance Rather with PCCI. I oversee our community vulnerability compass as well as our work with United Way and our DCBI data capacity building initiative with United Way. And what we're trying to do is break down some of those silos. You're absolutely correct. When we did AHC work, we saw in general people had 2.6 health-related social needs. And so what we need to do is break down the silos through the data capacity building initiative as well as CVC. What we're seeing is we're able to create a shared language between CBOs, healthcare organizations, other community partners, so that we all have the same data. We're all looking at the same thing, being able to speak in a way that we haven't been able to before, so that we can bring about change in a holistic manner to geographies that have systemically been underserved and vulnerable, so that we can really holistically help things like food insecurity, education, where these things are tipping points and pulling points and leverage on one another so that we can bring about that change. Great point.
And kind of a follow-up on that, I'm Teresa Daniel from Dallas County. Public health, public safety are what we do. But it's in that partnership with Parkland and the variety of clinics and healthcare system that to me just like, once again, it's a system. And that if we do not approach matching up our patients with the services they need, and that includes the transportation, education, support of family, I mean, just all the other things that I've already mentioned. So I really appreciate the work that students are doing in this area because it gives us one more piece of ammunition to tell the story of what are we doing and what are we trying to do for the health of residents of Dallas County. So thank you very, very much. And for the aspect that it's a system that we have to address. Thank you.
Mohammed again from PCCI. What was your favorite thing about this whole project, learning or whatnot?
A very broad question. There are a lot of things that I've done. I couldn't pinpoint my favorite thing. I would say this entire experience was amazing. The entire experience was my favorite thing. Getting to learn something new, getting to work with people, getting to have one-on-one time with my mentor and our project manager, and being able to see the back end of data, being able to understand where this data is coming from and the patients that we're looking at. I think because I am from Dallas and I'm very familiar with the areas, it kind of hit closer to home for me. So I was very, very interested in this project and I'm glad that I was able to be a part of it, honestly.
That's okay, we can.
Okay, we're gonna move on. Thank you so much, Trinity.
Yeah, thank you all.
Everyone. And I'm originally from Eastern Africa, Eritrea. I'm currently studying computer science at Methodist University, also data science. Some of my hobbies are playing sports, and also I like fashion and design overall. And I'm also Christian. So my amazing experience here at PCCI this summer, I had the privilege to visit the Community Vulnerability Campus Training for different organizations, which I'm going to use the CVC in a similar way. I also had the amazing opportunity to tour the wonderful mobile Parkland clinics, and also we also volunteered with the team as well, as you can see. And then I also learned new tools like Power BI and Databricks. My project is over maternal health, specifically severe obstetric complications, or you will hear me say SMM, which is also severe maternal morbidity. It includes often life-threatening and life-threatening. It includes often life-threatening outcomes of delivery or pregnancy that may impact a mother, like long-term or short-term. The United States has one of the leading cases from the developed countries, from 50 to 60,000 cases a year, and about 200% has increased from the year 1993 to 2014. There are about 650 to 750 deaths each year, and 77% of the deaths are maternal-related deaths are caused directly by SMMs. During my first half of the summer, during half of the summer, I did a literature review. I also saw how community vulnerability can impact the SOC rate in an area. And I also mapped out the demographics in that area, and I used Power BI to show the interactive dashboard of how these are mapped out, and also the dashboard of the age and ethnicity as well. When talking about SMM, it's crucial to understand who's at risk. According to my literature review, Black women are 3 times more at risk than white women. Also, Hispanic women are 1.5 times more at risk than white women as well. And as you can see, women under Medicaid are also 2 times more at risk than people. And age also has plays a role in like being older than 40 or younger than 18 as well puts women at risk. As you can see, 60% of these complications are preventable with the right care, which is why using data like CBC and finding the root causes would help prevent these. For the data source, I use data from Fort Worth Hospital Council from 2020 to 2024, including SOC counts and zip code at a zip code level, as well as age, race, ethnicity of the patients. I also use CBC data from PCCI, which are the non-medical determinants of health, for example, like education, community vulnerability, and so on. My approach involves, instead of using row counts, I use prevalence, which is dividing the SOC counts per the delivery on that area. And then I use that to map out most of the maps and the graphs. And then I also use Power BI to show the maps, what I'll show in a minute, and created a correlation metrics to show the numerical correlation of these factors as well. Finally, I used ridge regression to predict the needs in 2024 for transfusion. So right now I will lead you to the dashboard and how you can use this.
It's up. Who's up?
Oh, okay. Sorry, I can see. So I'll look down here so that I can kind of help you understand what's going on. So on the left-hand side, you can see there's a drop-down menus. There's if you click anything here, you will see they have the option of any SOC, severe obstetric complication. there's a whole category that you can pick in. For example, if you pick in on maternal health related, you could see the graph of Dallas and Tarrant County being the dark blue being the highest and light green being the lowest one. So if you click here on transfusion by itself, because it's one of the highest rates, you can see these dark areas being over here, being the highest counts of SOCs per delivery. So also, you can see the community vulnerability campus over down on the center, where if you zoom in, you can see that the highest vulnerable areas are also more likely to have more counts of SOCs, prevalences per delivery. You could change the type of CBC you want to compare it with. You can have it as mental health. You could see these areas also being any of these 33 instances that I have right now. You could choose and compare it to see a visual correlation over here. For now, I would just put it in somewhere around health insurance. Yes, I will choose health insurance so you can compare it with vulnerability in health insurance and the CBC with this transfusion for the SOC. As you can see, you could also choose the time of SOC. For now, I have it as 1 year. You could choose a quarter. For example, if you choose a quarter from 2023, it will show only the quarter. You can also put all the years from 2022 to 2024 to show you the prevalence on that as well on this area. For now, I'll put it in 1 year so then I can show you the prevalence per year for this higher rate over here is beyond the average of the nation. So if these are darker areas over here are more likely beyond the average of the nation as well. And then you could also choose a zip code in here. You could choose the whole one county, just Tarrant County, or also you could just pinpoint to any zip code that you want to see as well. I have Tarrant and Dallas County right now, and I have chosen both of them. So over here, as you can see, almost 3/4 of my data was transfusion. From the SOC counts, you can see this is anything that SOC, this green area right here, and this blue area right here is transfusion. So as you can see, if you click on an area over here, you can see the rates changing from transfusion to anything but transfusion rates. If you also move down here somewhere around here, Dallas, you can see the route-specific SOC being more than transfusion. So also the age prevalences over here, if I zoom in, you can see the youngest being most vulnerable, also the oldest being most vulnerable. And then you can see the year that's being prevailing from 2022 to 2024. If you click on an area as well, you can see how it's been prevailing. It depends on whatever you're selecting from both sides. It can show up here. And then also you can see these also by prevalences, like how many Black patients did we have that had SOC also delivered. So and if you click on different areas, it depends. Also that will change. For example, if I click on here, you'll see that. And yeah, everything just depends on whatever you're clicking. And it just gives you an overall trend of similar things happening over and over again, the race, age, and so on, as well, how it's been linearly increasing over the years as well. To go back to my slide now. In order to see the numeric correlation, we built a matrix that shows the top correlated indicators of CBC. Mind you, this is pure neighborhood data. We're comparing to patient level data. So this over here, you can see the transfusion, any other SOC, and anything except for transfusion. You can see that diabetes and health insurance coverage and some of the other indicators being the top. These are the top chosen indicators as well. As you've seen, transfusion being 3/4 of my data average SOC counts, we plan to move with transfusion prediction. Transfusion is a blood loss after or during delivery and can be caused by hemorrhage, placenta issues, or delivery complications as well, like tears. After trying a couple of models, I stick with ridge regression, which is a type of linear regression that adds penalty that discourages large coefficients. For example, if some coefficient value is really high, it kind of like discourages that, and which it helps the prevent overfitting the data. So the model was trained on 2023 to 2020, 2020 to 2023 transfusion of the past data, using also CBC, age, and race, individual features, all of them in a split of 70% training and 30% testing. As you can see, the model was able to capture almost 90% of the variations. In this outcome, the top predictors, as you can see, are the transfusion past years, but also you can see that some of these diabetes and good health, neighborhood safety, and so on playing a role in being the positive predictors. As you can see, mid-age and cancer and so on are also the negative predictors as being predicting transfusion in the upcoming year. So some of my limitations during this process is that I had no prenatal visits. So information I had about patient is about their vulnerable areas rather than about their personal information. So that was kind of a limitation. And something else I had limitation is some of the SOCs have really low counts. So predicting those was kind of challenging. So which is why I moved on with predicting transfusion itself. So some of the next steps that could be possible taken, this is just the beginning of the project, is risk alerts for hospitals to use when they have a patient, or they can reach out to a patient so they can see who's really at risk and send help before it's too late. And then we could possibly have a monthly predicting transfusion or some other SOCs as well. So then the hospitals could be rated and resourced, like blood, for example, for transfusion. And also something that can predict other than transfusion as well. So a model that can predict something other than transfusion as well. So if you haven't gotten everything that I've explained about SOCs, I will leave you with this. This risk, this complication that's putting mother's life and a baby's life at risk can be prevented with the right care. So using data like CBC and other indicators of health, we help to assist mothers to early reduce the count of these numbers. And I also want to thank my mentor, Youssef. I do want to thank Lance for helping with the dashboard and everybody, PCCI team, and my also.
Really great presentation and kudos for doing a live demonstration. I'm curious about on the dashboard, when you're talking, you mentioned that you have some low numbers of SOCs. Is that something you considered with the dashboard, especially when looking over trends over a year, or is that something to consider in kind of future work?
Oh, that's a really good question. So really had challenging point of mapping some SOCs because they were really low counts. So I was gonna do something as in like putting them in quantiles or something so then we can have really low counts as a low burner one. That was really also hard because some of them were really low. Some of them have really low numbers, but as you can see, I use gradients over here. So then we can see the lowest being like none, as you can see, being green, and then it can gradually increase color. So then we could see the prevalence of the SOCs. If some of them didn't have any SOCs in them, they would say pure green, but it kind of adds color to it when there's more prevalence in an area. So it was really challenging to graph out some of them if I was using quantiles, for example, similar to the CBC where you could have from 1 to 5. But I use just gradients, pure like numerical counts of these, so then all of them can count out. Thank you.
Perfect, thank you.
And with the predictions you were making, were you looking to do predictions at a patient level or a geographic level for more interventions in that area?
I should have explained before. Yes. So our prediction was basically so I kind of did transfusion for 2024 per zip code. So the counts, basically this model was able to count how many transfusions can happen for 2024 on a zip code level.
So helping to lead towards more of a surveillance system to really know where those impacts in the community, the outreach, the education need to go.
Yes, exactly. Tell like the past transfusion rates were the most prevalent ones that we used to predict this. So some of these CBCs were really important, but the past data from transfusion also helped out and to see how many we're going to get.
Thank you for a great presentation and thank you for walking us through the dashboard as well. Really, really helpful. I guess on the PCCI, through your analysis, are there some indicators for women who don't visit necessarily the health system that we can do some sort of outreach or alert to risk for SOC before it happens, right? They have some previa or some sort of like challenges where they may not encounter a physician who can let them know of the risks that they can take care of themselves. So proactive outreach.
Yeah, that's a really good question. As also my project relates to Anne's really correlates on how the prenatal visits also matter into this. We didn't have prenatal. This is all postpartum data that we have. But as you mentioned, some people may not be able to go, or some people went and just never went back, or some of these other reasons that they're not there that could cause these complications. I would say some of them are really like personalized, like it can happen during surgery, or it can happen as I've showed in the dashboard also, there's like a surgical problems that can happen. You really cannot like reach, like help with these, but you know, kind of in the situation. But also I would say a lot of different factors like obesity, for example, in an area, because cesarean C-section also puts high risk of this transfusion or any other complications. So I would say like more health correlated education, like overall, like women, I think should be educated about these things from the start. I would say this is something that also, as you mentioned, in the system that has to be implemented. So people already know about these things. But yeah, mostly I feel like is about personal health and how the person is taking care of themselves. So being in these vulnerable areas maybe expose them to like different things or no knowledge about these things as well. So it's about the system, I would say, learning from the beginning about how to take care of these things.
Excellent presentation. Thank you for that. This is such a critical issue, as we know, not only in our local area, but nationally, as we discuss maternal morbidity and mortality rates, and having such a high rate in our country is definitely a challenge. One of the things I will just to kind of put out here that we may want to also consider, I like the fact that you kind of use transfusion kind of as the parameter that you were assessing in terms of really understanding the risk factors around postpartum hemorrhage, which tends to be the highest, most severe complication that we tend to see, right? And there's multiple factors that can contribute to postpartum hemorrhage, and transfusions often are a result of postpartum hemorrhage. And the most vulnerable time for a mom is that 24-hour postpartum, right? So I think this is great. I think one of the things that would be good to capture that we forget oftentimes is that 7-day window. And there's also very much a high risk there. So if you can actually correlate it, not to just transfusion, because they may leave without a transfusion and the postpartum and the hemorrhage occurs later, but the risk factors that are associated are severe preeclampsia, hypertension, cardiomyopathies, all these other things, and adding those diagnostic codes into that to understand that you have a patient who's at risk and leaving with that, they are also significantly vulnerable for mortality rates are high. So I think it'd be great if there was a way to kind of think about that in terms of those diagnostic codes and considering capturing that 7-day period. If we go even beyond that, we understand too that even up to 1 year, then you're dealing with mental health issues, postpartum depression, things like that too, that you can correlate also. But you can think about that in kind of a timeline that you can capture as a severe complication, some of those other factors.
Good morning, everyone. Hope you guys had like a good break. It was a short one, but yeah. So get ready with me to like go deep dive in my project, which I have worked over the summer. That is automation of PTIM pipeline using AWS infrastructure using an IAC tool. We will be going through each and every term which we have used over here in deep. So first of all, what we are going to cover over here is we are going to talk about myself, about the project. We are going to explore. We are going to talk about what tools I have explored throughout the summer, what showcase, like what infrastructure I've built till now, and what are the next steps and the future steps for this. So about me, I'm from India and currently I'm pursuing Masters in Engineering Science, Data Science at University of Buffalo. And I've done my undergrad back in India and also I have like work experience of like 3 years as a software engineer. So like if you go to the photo wall, that's like a picture of UP and Buffalo has some of the worst snows in winter. And coming from India, which is like the hottest temperature I have lived in, this was like a really good experience. Then I have my support system, my family over here. I'm a big anime fan. I've done classical Bharatanatyam dance in my childhood, and I'm also a big nature person. So I like to like roam around. I like to have like some adventures and some of the risky rides. Okay. So why we are doing this automation? This has been developed for the PCCI with the goal of automating the infrastructure deployment for the PTIM model. So while we have like potential clients like Grady and Parkland in mind, this is going to be an artifact specifically for PCCI, which is going to give us like benefits like a reusable, secure, and scalable automation framework. So I had like one of my best time while visiting my visit with the Parkland with Dr. Star. And I'm thankful for that. I'm grateful and I really would like to thank Miss Ida and Miss Kristen to arrange it, organize it. Many times when we are working behind the screens, we don't know what our tech is doing outside in the world. And that's what I got to see. I saw the PTIM dashboard, how it's working and how how is it helping like make a better change in the society. Thank you. Then, okay, let's go into the projects. So some of the Q&A is just one question. So when we think about like infrastructure, like healthcare infrastructure, what does it come into your mind? You guys want to answer? Like any infrastructure, like suppose you're building a hospital. So what do you need to set up a hospital? Procedures?
Networks.
Yeah. Networks. Yeah. So when we're building a hospital, like a building, it comes most to the hardware one. But when we are building a tech infrastructure, what comes into our mind is like building servers. We have to build the networks. We have to build the security along us, like whatever the computer, whatever the tech we are going to use. We have to focus more on the security. So this is what infrastructure means. And what IAC means is like infrastructure as a code. We have to build this as a code. So this is what we are going to talk about this project. We are going to build the infrastructure automation and what sort of POC I've done throughout the summer. And the machine learning model, which I'm going to use over here, like which I have used for this infrastructure to automate it is like the PTIM pipeline. That is like a Parkland Trauma Index of Mortality. It is a more of like a system developed by PCCI to help the clinicians to predict the risk trauma score. So like we have already talked about what IAC is, but what benefits, what are the sort of the benefits we are going to get from this project? So that is like we are going to have like our automation, we are going to have consistency across different platforms, we are going to have faster delivery, we are going to have reduced errors, at least it's going to be automated and it's going to be at a one code to a different platforms. And we are going to have like a different version controls and we are going to obviously save operational cost while setting up the infrastructure. How it can be implemented. So first step is obviously to have in our mind what sort of infrastructure we want to build, like what sort of servers, what sort of like different tech infrastructure we want to have we want to build. Once we have that in our mind, we can have it controlled like version control using like some of the Git repos, like which we are using over here is like the Azure DevOps. Then we are going to automate the provisioning and then we are going to continuously monitor and manage that infrastructure. So why does it matter? Is basically, we'll take one example, like suppose during any of the natural disaster or a cyber attack or any of the power outage, if our infrastructure goes down, how quickly can we get it back up and running? Using the manual steps, it can be like take weeks or two, and obviously it's going to have more manpower around it. But while automating, we can get it back up within a day, along with some sanity testing in place. Now, PCCI's cloud evaluation. So basically right now in PCCI, we are using Azure as a cloud services, but this is the first time which we are going to move into AWS and I'm grateful to be part of it. And this is going to be our first, basically it's going to be adding a new chapter into the PCCI or adding into the AWS. as we talk about AWS, that is Amazon Web Services, it has like many services, but these are some of the basic services which I'm going to cover today, and we will be going in detail in each one of them. Okay, so in industry, we have many tools available, like for the infrastructure as a code tools. But one of the one, like we have explored each one of them, and we have selected like Pulumi as our tool. So why we have selected Pulumi is basically it allows us to use our own known programming languages, that is Python, and we can code in our own language what infrastructure we want, and we have designed that, and we can make it live. We can make it integrated with along with like different cloud platforms easily, and we can have like multiple. Yeah, so we can have like multiple AWS components integrated along with that. So this is a simple architecture diagram here we have. So basically at the heart of this place is like the Pulumi CLI, which is gonna be our main part, which will take our Python code from Pulumi, like Python code along with the Pulumi CLI. It will create our AWS components. And along with that, we also have to talk like how do we manage the state of our architecture? So when we talk about state, what does state means? Like what state, like how our architecture is being deployed, like what sort of like features we have changed once we have like deployed it. So to see that, we have like 3 state management available in Pulumi. The one is like the locally management. The second one is using the cloud platforms which we are going to deploy in. We can use a AWS CLI or Azure. And the third one is using the Pulumi cloud, which is available for us for the free. Now, I talked about this earlier, for version controlling, we used Azure DevOps, right? So to have our automation, I've developed like 2 pipelines over here, which like the first pipeline is going to be the IAC deployment, where I'm deploying my whole AWS components, which you can see over there, that is Event Bridge, SQS Event Queuing, S3 data, S3 bucket, we have 2 lambdas over here and Docker images. These all things like the whole infrastructure is getting created within just by running this pipeline, which is running like within like 2 minutes. So that's like something which we have automated. Now the second pipeline which we had was like, now the focus is more the focus is around like Isthmus PTIM pipeline. Like this is the code which we want to deploy in our infrastructure. So the second one is like we are creating a Docker image of that code and we are pushing it to our Amazon ECR Elastic Container Registry. Now this is like, I know, don't look at that. I need to explain. Okay. So this is what the infrastructure we have like defined, and I have like a small diagram over here. So the first part is like the heart of it is like the safeguarding the PHI data. How are we handling the security for our PHI data? How are we managing keeping it secure from the outside networks? So here we have used one of the Amazon Web Services, that is virtual private cloud. This is a private cloud which has like, we are defining the outbound and inbound traffic using that route table. And we have only one outbound network available over here, that is just to call the Epic mockup APIs to get our patient data. Other than that, we are not allowing any connection outside. This is just for the POC purpose, but along with that, we also have a separate virtual private cloud, which is filtering out our requests, if they are the valid or if they are legit requests. So that's how the security, that's how the privacy comes in play for our private data. The second one is like the PTIM pipeline automation. What sort of automation, like how we have worked around that. So if you can see over there, we have like the event bridge scheduler, which is running every 1 hour, which gets triggered. It triggers our first Lambda. What is Lambda? It's a serverless code space available in AWS services. So one of the pain point during our internship was like majorly for my colleagues, it was like, Databricks, right? But using Lambda, I didn't have to face that issue. Why? Because it goes scale up and scale down based on my own needs. If my program is doing more high, if my code is needing more space, it can use it. The same goes with like, if you see a red box around it, that is a security group. That's another level of firewall which we have added. That is also defining what sort of networks, who can access these services. Most of our PTIM pipeline code is available inside that 2 lambdas. Like the first lambda, which is getting triggered from the event bridge, is gonna trigger our system list API, which is gonna get the patient IDs. Once we have that patient IDs, we're gonna post it to the Amazon SQS queue. Once the patient IDs are posted into Amazon SQS queue, it's gonna trigger us the second lambda, which is EHR ops data. which is gonna get our location, contact detail, all this data. It's gonna hit this APIs and get this data, and all of this data is stored in our Amazon S3 bucket. This is how the whole PTIM pipeline automation works. Now, and yeah, so why we are using Amazon SPSQ? Instead of that, we could have easily done like system list to EHR ops. We could have called like literally post the patient IDs to EHR ops. But why we are doing that is because we are going to make our architecture as an event-driven architecture. And why we want an event-driven architecture is because like both the lambdas are loosely coupled. Once system list has posted its patient IDs to Amazon SPSQ, the system list does not have to care what happens to that patient IDs. The queue will store it. It will keep retrying until and unless it's processed. So this is one of the feature we have. And just keep in mind, the first pipeline which we talked about, it is going to deploy whole architecture in our Amazon SPSQ within 2 minutes. Yeah, so we had like 3 phases implementation phases over here. The phase 1, I explored like different ISC tools. I explored the AWS cloud services. I also learned the DevOps basics. In the phase 2 and phase 3, we implemented our pipeline, we implemented our code, and we also like went on to the monitoring and documentation part of the project. So what we have achieved till now is like we have worked more on the reductions of the operational cost. We have reduced our operational cost. We have like achieved our consistency. We have achieved our automation. And we have like a faster, repeatable infrastructure deployments. You can do it with any cloud services and with any machine learning model. And what's next is making it available across multiple hospital systems. And in future, when we have done all this, we can have like an AI come into play in our picture. That is an agentic AI implementation, having a chatbot which can just deploy the infrastructure for you. These are my some of like internship highlights from the first day with Ms. Christina to the last day from the potluck. And I'm really thankful for that. Thank you so much, guys. And yeah, thank you for mentor Shilhat Ali and
Thank you so much for our presentation. My name is Vince from PCCI. Question related to what I did was from the implementation from an infrastructure. It's a big job. What happened? Because my understanding is cloud, you already, whether it is Azure or whether it is AWS, it provides out of the box most of the system for automation plus this. My question revolves around the DR factor. So let's assume that one of the system goes down. How does your system helps in recovering live system, which is like PTIM, which requires a real-time score availability? So if you have to implement a DR, what do you think your pipeline or your implementation helps in that area?
So when we are talking about this POC, we still have to like implementing the next steps. We have to implement a Lambda, which is going to perform our risk scoring factor on the PTIM application. PTIM machine learning model. But when once we have our whole infrastructure is down, we can just run this pipeline and we can get our infrastructure up and running. And then we can perform the sanity testing of our component is working fine.
Lance Rather, PCCI. I know you mentioned that it looks like you're pushing this in about 1:37 seconds for standing this up or 2 minutes. What's the time savings there? If you had to do this manually with each piece of the infrastructure, what's your estimated time savings?
So at the start of like when I was learning my AWS services, I did this manually and it took me around like 2 to 3 weeks just to get it done. Because when we talk about this VPC, it's not just alone VPC. I have to design the security group, I have to design the route table, I have to design the NAT gateway, the internet gateway, and the API mock API's endpoint just to make it working. So it was very good.
Sorry, we got a question from the chat from Yolande. She said, great work. How is the PTIM model automation translatable to other PCCI models? So what would it take? Would it take the same time or effort, or some of the building blocks reusable? So I guess could we transfer this to the other models we have?
Yeah, that's a great question. So when we see this our pipeline too, that is deploying our Docker image creation, the Docker image has the code for the PTIM pipeline. So what we need to do to transfer it to other machine learning model is to just have that code to create the Docker image, and we just need a Docker image to deploy it. But yeah, in terms of like when we need to design, if we want the same set of infrastructure, we can deploy it within like a week just to make some like small changes. But if we have to deploy, like we need more infrastructure, then that might take some time or some understanding to how to add this, like how to add this between our previous infrastructure.
Thank you so much, Pooja. This is Aida Sam from PCCI. Great work. A lot of appreciation and respect as fellow woman engineer coming through the ranks, and cross-poorly really applying systems in a meaningful way. What are some of the insights that you learned and how they've contributed when you did visit and speak to Dr. Starr and the trauma team? Can you talk a little bit about that experience and how has that really affected the way that you've designed the system?
Thank you. I mean, thank you so much for giving me the platform to talk about it because I had to rush through my presentations today. So when I visited with Dr. Starr, it was early in the morning and they had their own like brief overview about their patients, and it was like right after a long break, and they had like more severe patients like gunshot wounds and all that, and like they were discussing like the whole thesis, like what the patient treatment plan is going on, like how is it like getting like treated, and like basically it was like a orthopedic surgery department, and it was like a trauma center. And at the end of that at the end of the meeting, Dr. Starr went to like the PTIM pipeline dashboard, and he went to like every patient score, and he saw like what were the patient scores, like which were more risk, like which were like having more risk, like it was above 50, but like two of the patients had like more score that it was above 50, and they talked about their treatment plans about that. And also Dr. Starr like quizzed their fellow doctors about what are the important features for this PTIM pipeline. And from there I learned like it was like age and the GCS scale. So that's how the whole visit was.
And the importance of the
Yeah, so basically I realized that right now when the PTIM model which we have in our Parkland, that is on the Azure cloud. But to make it available more on the different cloud services to different clients, we can offer it like based on their own preferences, which cloud services they prefer at their own terms, and we can offer it more to different PCCI clients. Yeah, the expand the version.
Thank you, Pooja. Let's all give her a round of applause.
So first I'm going to talk about some background information of the project, followed by some methods we're planning to use. And then I'm going to talk about some EDA results and the model we test and recommend to use. First, a little bit about myself. I'm a second-year stats PhD student at SMU. I'm from Shanghai, China. And two of the most important things for me, surprisingly not statistics, are food and music. It really comforts me when I'm stressful. So back to our project. Our stakeholder is Dr. Moran from Parkland Hospital. And our thank you so much for giving us the honor to study on this project. And our objective is to develop a digital safeness index to access patients' engagement of using MyChart. By trying to develop this digital engagement score, we are trying to understand patients' engagement patterns of using MyChart. This will help Parkland to tailor their communication strategies and digital health services to better serve different patient segments. So we are going to use machine learning models on our data set, trying to sort our patients into 3 different groups: highly digital engaged, semi-engaged, and not engaged.
Our data set is a combination of information from census data set, Parkland Health and Hospital Service data, CDC, SIGGRAPH, FCC, which is the Federal Communication Commission data set, EPIC, which provides lots of detailed line chart usage information. I'm going to talk more about the more detailed features in this data set in my EDA result and models. So this is an encounter-based data set. Each row is a visit. It includes outpatient encounters of Parkland Hospital in the year of 2024. And in our training data set, we have a total of over 1 million encounters among over 200,000 patients. And everything is aggregated at patient level for analysis. So the methods we're trying to use here is unsupervised machine learning model. So for example, this collection of roots on the left side is our data set. And without telling our algorithm what is an apple, orange, or banana, we're trying to let the algorithm decide itself, learning from the data set and sort it into 3 groups, hopefully bananas, oranges, and apples. So in our case, without telling the algorithm, for highly engaged, semi-digitally engaged, and not engaged, we will feed our algorithm the data set and let it sort our patients into these 3 groups. Some demographics information summary. Our average age of our cohort is 44 and median age is 47. We can see that our average age is slightly lower than our median. This is due to the large group of newborns at Parkland Hospital. We have about 4% of our cohort has age less than 1. And by including these group people in our data set, we are trying to understand how care provider and parents use MyChart for the kids. 2/3 of our cohort are female and 65% are Hispanics, followed by 30% non-Hispanic. Our leading race group in the cohort are white, about 73% of them, followed by 21.5% Black or African American, and we only have about 2% Asian, Native Hawaiian, Pacific Islander. PHHS dataset also provides detailed MyChart usage information. So among all the encounters we have, there are about 16 of them are virtual visit. As I mentioned before, our cohort size is about 200,000. And among these patients, about 83% of them has an activated MyChart account. And among these people who has an activated accounts, about 82% of them actually use some features in MyChart. So we can see that we already have a good amount of patients are using MyChart. It will be great if we can encourage more patients to use the portal and to make the visit process more easier for both the patients and hospital sites. SafeGraph dataset provides average total monthly visit count to different industries. Everything is really skewed in this dataset, so our power transformation or performance. We are including these features in our model is because we think how often people visit industry like libraries or education institution could be highly related to their digital savviness, and how often they visit technical service could be related to their access to internet. FCC dataset provides information of number of broadband providers and tech types at a block group level, and it also provides information of minimum and maximum speed available for broadband. For the modeling stage, we tried 5 models. By looking at the elbow plot for k-means, the optimal clusters suggested are 3 or 4 clusters. And so further look into how much information these models explain. 3 clusters explains about 89.4% of the variance, and 4 clusters explains about 90%. So at this level, these 2 models are not that different. But look at the results of the clusters. We figured that the full cluster, the actual cluster it has compared to 3 clusters, is just separate our highly engaged group into 2 groups, which is not really necessary in our case, since our main goal is to figure out the group who are not engaged and semi-engaged. We also tried Gaussian mixture model, DB scan, and neural network, so we can look at our data set in a different perspective. By looking at the SILO score, we can see that K-means with 3 clusters and neural network has the highest score, which means the best performance. And it's not surprising that neural network has a similar score as K-means 3 clusters, because due to a time limit, the way I built it up is I applied K-means 3 clusters first to build up the label and use neural network as a supervised machine learning model. So gathered all of that information. K-means with 3 clusters is our best model here. It's the easiest one with the best performance. So look into more results for our K-means clusters with 3 clusters. 47% of our cohort lands into cluster 0, followed by 29% in class 2 and 24% in cluster 1. By looking at the summary of each features among all the clusters, we decided that class 0 should be our highly engaged group. Cluster 1 is the not engaged, and class 2 is the semi-engaged. Now we have labels for our patients. Let's look at some similarity and difference between our 3 groups. So for all the 3 groups, female is the leading gender, which is not surprising since 2/3 of our cohort are female, and highly engaged has the highest, largest female group in the cluster. For both highly engaged and not engaged group, you can see that the leading group is Hispanic and white, while for semi-engaged, we have 99% of non-Hispanic and about 95% of Black or African American. For age, not engaged has the eldest and semi-engaged has the lowest. But by looking into more detailed age distribution for each cluster, I actually find out that minors are the major group in not engaged, which are patients with age less than 18, and elderly is the leading group for semi-engaged, which are patients that's elder than 65, and for highly engaged, the leading age group is mid-age. For MyChart usage features, we included, do people have activated MyChart accounts? Do they use the features? And for the specific actions we have from our EPIC dataset, we have they ever used MyChart? How often do they use MyChart for payment, cancel or request for appointment, check their appointment, and upload files? So for highly engaged cluster, it has the most activated ratio among all the 3 clusters and the most usage of almost all the actions. For semi-engaged, it has a higher usage of request appointment, upload photo, and for not engaged, it has the least activated ratio and least usage of all the actions. We check the effect size of all the features to see how big is the difference between the clusters. So for all the features from CBC, SIGGRAPH, and FCC, there's no big difference between the clusters. But for features like age and the actions like payment, completed visit, confirmed visit, upload files, things like that are very useful to how the algorithm separate the clusters here. We also included the total encounter count as one of our variable, and the average total encounter between the 3 groups are not so different from each other. So this indicates that the highly engaged group doesn't mean they visit the hospital more often. For next steps, we still have more data that we can pull from EPIC for more detailed MyChart usage actions. And Eric, my mentor, is going to keep working on this project after summer. So he is going to do an amazing job, build up more complicated and better models, build up on my work. For some limitation of this project, for some of our features from FCC, SafeGraph, and CDC, they're all at block group level, and we did analysis at patient level. So that's probably why those features didn't seem so different between the clusters. And another limitation is that we use cluster modelings, which the results could be very subjective. So things I learned from this program, I learned so much about how to deal with real-life data sets, aggregated features differently based on their different characteristics, and just realized I still have a long way to go to become an amazing data scientist, but learned so much during the past 3 months on coding and how to deal with a real life situation. And so I think it's a great start of the career path. So thanks to my mentor, Eric, for all the support. Thanks to Parkland, Dr. Nguyen, to give us this amazing opportunity to study on this digital engagement. Thanks to Estefania, our project manager, for arranging everything. And thank you to everyone on PCCI team for this amazing summer.
Nancy from PCCI. So this was a great presentation. So the amount of data discrepancy that you had was wide area. So my question is related to the block group level implementation. I know when you go to that level, you have overlaps when you specifically have around zip code. So how did you handle it during your implementation? Was there any challenges to basically segregate block group level identification based on zip code, because there are certain boundaries which gets overlapped and the data may be murkier for measurement?
So the overlap?
Or the block group IDs. So basically when you have the data aggregation, like for calculation, you may find some data that is belonging to 2 block groups in the same zip code, right?
Oh, yes, right. So we do have patients that's kind of change address at some point in year 2024. So right now we just use them as kind of consider, because kind of want to see what's that does change address, change block group actually affect how they they fall into different clusters. So right now we leave them as considered almost different patient data points. So to see the result, but we did need to figure out furtherly to see does that actually make a difference.
Thank you.
Yeah.
Great presentation. As a non-Hispanic male in his 50s, I'm insulted that we were the least engaged group.
Need to convince more people to use it.
What do you think because it sounds like there was a lot of maybe volume in the pediatric age group, and there's a lot of complexity with proxies and parent access and things like that. Did you look at removing that and just looking at the population 18 and above? Did that change your predictions? Is that something that might need to be considered? You talked about like 4% of the population were newborns.
Oh, did I remove that part?
Yeah,
or did I
remove that because
yes, we kept that in our cohort so that because for them, of course, they're not using my chart themselves. And hopefully not. But they do visit the hospital for some reason, and their care provider or their parents will use the MyChart for them. So including them, we include them in the cohort so we can also figure out are their care provider or parents are using MyChart for them. So we can see that from non-engaged group, actually the minors are our major age group.
in not engaged. So in this way, maybe we can see that we can encourage parents to use my chart for their kids in the future to be more engaged.
Sure. No, I think that was appropriate. It just may be useful also to look at the data with removing the pediatric group, just because there's some complexity with parents getting access. That may have made it look a little bit different, the data. But otherwise, great project. And I just wanted to, for the people in the room, this is the kind of information that's going to help Parkland better engage our patients, and not that we're going to go to paper with the people that are less engaged, but actually we're going to spend more effort trying to engage them digitally and teach them and do digital support, digital fluency to help them. And this will help us be able to allocate our resources appropriately to those people who need it most. So this excellent presentation. Thank you.
Thank you so much.
Yeah, I just wanted to contribute on that. So originally, she did develop the models, we did eliminate the minors, and we saw very pretty much similar patterns. But then we decided to put them back because we thought it was also still important to capture how their caregivers, whether they're savvy or not. But when she first developed it, we did remove them, and the patterns are pretty similar. Oh, Eric from PCCI.
Thanks, mentor.
Online question from Dr. Lond. She says, great work. How do we explain that the same demographics both skewed towards highly engaged and not engaged? For example, females are both leading the highly engaged groups and the not engaged group. How about males? Thank you.
Right, so I do think we need to, next step is we really need to look into these groups and see why maybe it's leading to different clustering. And right now, for why female is the leading group is because mainly because 2/3 of our cohort are females, so 67% of our patients are female. So it's not that surprising that female is the leading gender group for all the clusters. But for the why we have more Hispanic and white dominated for both highly engaged and not engaged, we need to further investigate that. Thank you so much for your question.
Great job on this. This is something that I think dispels many myths that we may have, or preconceived notions that our patients aren't as digitally savvy or engaged. And so I think it does highlight that. We've done something similar on our end to really look at portal use, and we found that we beat the national benchmark around that. So and so we were very similar populations as you have there. So one of the things I think might be interesting thinking about the next phase of that is not only utilizing the portals for that patient engagement component and enhancing that, but considering it by conditions too. And are there factors that you can break it down to see if they are more engaged in certain kind of chronic conditions or certain types of things that patients are presenting with? To the point we talked about pregnant patients too, how are they utilizing it? If they're at a higher rate versus less rate, utilizing that as an intervention potentially with your thought about engaging the patients too and teaching. So I think it just gives you such a great window into an opportunity to look at the opportunities where patients are engaging, what the differential differences may be in terms of what they're engaging with and how they're engaging that, and then utilizing that as some opportunities.
Thank you so much for your suggestions.
Thank you very much. Let's give a round of applause.